Welcome everyone to our very special speaker series program. We're the National Capital Area chapter of the Depression and Bipolar Support Alliance, and we're very honored tonight to have Dr. Andrew Nierenberg speaking. Eric will introduce him. Dr. Andrew Nierenberg is a major figure in research on bipolar. We're honored to have him, and I will turn it over to Eric to do the introduction.
Pleased to welcome Dr. Andrew Nierenberg. I have known him for several years through my work with DBSA National. He has been a tremendous supporter of the work of DBSA and has a national reputation in the area of bipolar and treatment-resistant depression. His bio is up here on the screen, so I won't read it in detail, but I just want to say we really appreciate your time here and being with us. And with no further ado, I'll turn it over to you.
Thanks so much for inviting me. It really is a pleasure and an honor, and it's been a great partnership with not only DBSA, but Eric and I have been collaborating on a PCORI project, and really that's been extraordinarily helpful. Let me tell you what I think I would like to do, and go over a couple of things, and I hope that you learn something new from what I'm going over. And I'll be talking mostly about bipolar disorder and a little bit about treatment-resistant depression. And these are my disclosures. I work with a lot of companies and have for many years, in part because I believe the partnership helps bring new treatments to people. So there's this wonderful quote from Hippocrates, where he said, "From the brain and from the brain only arise our pleasures, joy, laughter, and jests, as well as our sorrows, pains, griefs, and tears." And it's amazing that our brains work at all. I mean, it's really just, it's like a miracle every day. I'm amazed that I wake up in the morning. I mean, that to me is it's its own miracle. And the fact that such a complicated organ doing such complicated things can work at all is amazing, and that sometimes it can be dysregulated is in some ways not surprising because it is so complicated. And of course, you know Kay's work, and I'm sure many of you have read this. If you haven't, I certainly recommend it. About the ways that things can get dysregulated. Bipolar disorder is among the top causes of disability worldwide. It occurs at a young age, costs an enormous amount of money, and the investment in it is certainly not even close to how much it really costs. There are several types of bipolar disorder that are recognized, and the ones that are clearly recognized are 1 and 2. 1, of course, being with manic episodes, type 2 with hypomanic episodes. And 90% of people have other problems, especially substance use, or anxiety disorders, and also can have a lot of chronic physical conditions, and if not treated, can lose years of life, mostly because of cardiovascular disease, of all things. Lifetime prevalence, almost 2.5%, 2.1% for bipolar 1, bipolar 2, high prevalence. This is, in some ways, a simplistic spaghetti plot of the different courses that people can have. The reason I say it's simplistic is because each line represents an individual. And the problem is that people with mania can have depression, people with depression can have mania, and the third dimension would be anxiety. So people can have mixed features that occur both at the same time. And if they have bipolar 1, you could have spikes of mania with mixed and along with periods of depression. And with bipolar 2, it's mostly depression with spikes of hypomania, but you can still have mixed features that can occur. As I said earlier, you can have other comorbid conditions, other psychiatric conditions, co-occurring conditions that really can be frequent. And this is an odds ratio. So it's like, 2 to 1 or something like that, compared to people who don't have bipolar disorder. And I'm a little troubled by this sense of personality disorder, because I don't even know what that means anymore. I think that people can have dysregulations and some difficulties in different areas of their lives. But I worry about it being called a personality disorder. It's almost like blaming somebody for it, which I don't think anybody would ask for it at all. So I think it's just another set of dysregulations. And then again, I said earlier that, this cardiovascular comorbid conditions that people can have both in bipolar disorder and in major depressive disorder. And I think we need to do a much better job of making sure that very careful attention is paid to the cardiovascular health of people who have mood disorders. Now, one of the things with bipolar disorder is that of all the time that people spend not feeling well, that about 75% of that time is depression, whereas 25% can be mania or hypomania. And depression in bipolar disorder is one of the toughest things to treat, and I'll show you in a moment. There are only a few things that have been approved by the FDA, and a lot of people do things that are not FDA approved because that, they kind of run out of things. This is a classic study from Lou Judd, and what this is rather amazing. This was called the collaborative depression study, and the collaborative depression study followed people for many years, and it was naturalistic. Most of the people who were in this study did not necessarily get great treatment. This was probably, I think, in the 80s and the 90s. And so it's the closest thing that we have to the naturalistic course of what's going on. And what it shows is that let me just go back up. What it shows is that about 31, what's really rather amazing, here we go. So about people spend about a third of their time, or almost a third, 31.9% of their weeks, either with major depression or with depressive symptoms, and much less in terms of either cycling or mania if they're bipolar 1. And if they're bipolar 2, the burden is really with depression with about half the time. There was a question in the chat about euthymia, which is a fancy word of saying you feel okay. And I'm sorry I used a technical sort of thing. And of course, suicide is a big problem. Famously, Jimi Hendrix, you may know that he wrote a song about lithium, and Kurt Cobain famously had, and so did David Foster Wallace. The depression is usually associated with suicide. Suicide's associated with the depressed state more than anything else. To differentiate the bipolar versus the unipolar depression, bipolar has an earlier age of onset, more episodes. And it's probably a myth that what's called atypical symptoms, which is eating more and sleeping more, occurs more often in bipolar than unipolar. That's probably not true. And that's the hyperphagia is the fancy word for eating more, hypersomnia, sleeping more. What is probably true is there probably is more psychosis, which is more frequently having times of hallucinations or delusions. happens more frequently postpartum. And the only symptom that seems to occur more frequently is just feeling slowed down, surprisingly. We did a set of studies and collaborated with some people in Denmark to analyze the data to look at 6-month outcomes. And what you can see is that this is the level of depressive symptoms with the Montgomery-Åsberg Depression Scale. And this is moderate depression, mild, and no symptoms. So everybody came in with some symptoms. So you have one group that actually does really pretty well. And within 8 weeks, they feel better with systematic treatment and they stay there, right? This is the sort of good responder group. Then there's another group that gets somewhat better over time and then kind of has a little bit of a rebound. And then there's another group that fluctuates a lot, but eventually gets better. All right, so after 16 weeks, like 4 months, they start to get better. And then about 10% of people just don't respond. All right, and these people suffer terribly. And again, we need to know more about what's helpful to help people feel better. Let's see. What this is reminding me to say is that the same study, the collaborative depression study, looked at how long episodes last. Now remember, this is mostly naturalistic with not necessarily the best treatment in the world, but just following people over time. And whether it's the first episode or the 5th episode, you can see the episodes kind of last around the same duration. So this is the proportion of subjects who remain in episode. Everybody starts an episode, so it's 100%. And then it goes down over time, and these are the weeks here. What's interesting to look at is the halfway point, right? So at what point do half the people stop having their episode? And if you go across here, the way to interpret this, and then go down here, so half the people, about half the people here, have their episodes end somewhere between 16 and 20 weeks, which is like 4 months. 4 to 5 months is how long this can really last. And there are a couple of modern studies that suggest this is still about the same duration for people. What is really another problem, about maybe 1 to 2% of people, it keeps on going, right? You look at that, it doesn't change a lot. So anywhere between 2% here, 1%, 2%, it just keeps going, right? That's 100 weeks. That's almost 2 years. And again, I think we need better treatments to figure out what the heck to do. It's a complicated disorder, and it has to do with genes, and it has to do with what's called epigenetics, which is how the genes can respond to the environment. It has to do with environmental factors like early trauma, substance abuse. Can cause all sorts of neuronal changes that changes the circuitry of how the brain is functionally organized. Our brains are remarkable in that they form what's called functional networks. And the functional networks will change depending on what you're doing. And if you have neuronal changes, it makes it hard for the circuits to do what they're supposed to do. And then it causes behavioral correlates, behavioral changes like mood symptoms, changes in energy levels, activation, disturbed thinking behavior, and then you have some other things of functional outcomes making it hard to think. So what can we do, and what sort of treatments are available, is that there have been all sorts of treatments that have been developed over time, and particularly for bipolar disorder, there are some treatments that help more with the depression and other treatments that help more with the mania. Besides lithium and besides lamotrigine, all the rest of these are repurposed, originally antipsychotics, and they all sort of share a quality of affecting dopamine as one of the neurotransmitters. But there are a couple of more things that are here that I'll tell you about in a minute. The other thing, my colleagues and I last year did a study where we looked at prescribing trends. And what I want to point out here is that this is the antipsychotics. This is from 97, 98, all the way to 2015, 2016. And it's the percent of people who are treated with that. And what you can see here is that back in 97, 98, about 10% of people were taking antipsychotics. And in 2015, 2016, it's above 50%. So it's a huge rise in that, and a big drop in mood stabilizers like lithium over time. So it's been this trend of more of the antipsychotics, less of the mood stabilizers. And there are a whole bunch of anti-manic agents, which I won't go into all of the details at all. But I did want to point out that the response rates, right, for acute mania all hover around 50%. That's all about 50%, better than placebo, which is about 30%. But that means about half the people will not respond to any single medication, which is probably why people take more than one medication. And then if you move over to the antidepressant treatments for bipolar disorder, there are only 1, 2, 3, 4 that are approved by the FDA. There's the Zyprexa, Prozac, olanzapine, fluoxetine combination that very few people use. Some people do. It works quite well, but you have problems with olanzapine with weight gain and problems with the lipids and other things. Quetiapine or Seroquel has a similar problem. Lorazepam, Latuda, much less of a problem. And the new one is cariprazine or Vraylar. Lamotrigine is something that's frequently used for depression, but only approved for the long-term prevention of it. And this is what's amazing. No antidepressants are approved for bipolar depression. That may be a surprise to you because many, many people are given antidepressants for bipolar depression. And it's probably one of the most sort of controversial things in the field that's going on. There's a question in the chat. Latuda is not on the graphic of meds. Is it similar to those aside from lithium and lamotrigine? So Latuda is different. Latuda is an antipsychotic that has antidepressant properties and was approved by the FDA for the treatment of bipolar disorder. And there's another question about where does bupropion come in? So many of you may know bupropion, also known as Wellbutrin. It's very interesting that many people take it. Some people feel that it's clearly helpful. And there's no study that shows that it's better than placebo for bipolar depression, believe it or not. Now, it doesn't mean it doesn't work, but it means that on average, when you do the studies, it's hard to prove that it works. That's the problem. So bupropion is an antidepressant, and it is not approved for bipolar depression. Somebody's asking, what's the difference between serotonin and dopamine reuptake inhibitors for depression? So the dopamine reuptake inhibitors, of which bupropion is actually one of them, is a little different in that it doesn't touch serotonin. But nobody has necessarily found that these different mechanisms of action will have different levels of efficacy, except that they will have different side effects that can occur. So that's really the problem with that. Let me just see if I can fix the mic a little bit. so people can hear me better. So
Andy, you seem,
Lost sound.
yeah, Andy, you seem to be muted now. Your microphone got turned off somehow.
how about now? Is that better?
Yes.
Yes, it is. Yeah.
Oh, okay. Sorry about that. Did you hear what I said about antipsychotics and antidepressants or not?
I don't
No?
think
Yes?
so.
Oh, no. Okay.
They-
So the antipsychotics and the antidepressants are frequently used, but surprisingly understudied. And just this week, we put in a very large grant to see if we can compare antipsychotics plus antidepressants to quetiapine, lurasidone, and cariprazine. Again, because so many people are treated with it, we have to really understand if it really works. Somebody else is also asking a question: are homeopathic remedies better for bipolar depression so you aren't pushed into mania? I'm not aware of any solid data on the homeopathic remedies. There are some naturalistic ones, though, like something called NAC or N-acetylcysteine. And there's some interesting data on that. Some mixed data, but some that suggest it might be helpful. There's also electroconvulsive therapy, which there's some studies that compare it directly to medication. I may have a slide on that. And then the repetitive transcranial magnetic stimulation probably does work, but it is not approved by the FDA. And that causes a tremendous problem with reimbursement from the insurance companies. Sometimes they won't pay for the RTMS if somebody has bipolar depression. All right, let's see. Oh, there we go. Sorry. And remember, I was saying before that the antidepressant prescriptions really, if anything, they're going up. So in blue, in 1997, 98, about half of people were taking it. And then you go all the way to 2015, 2016, it's up to more than 60%. And there's a tremendous lack of data for this very common treatment that people tend to use. I just want to watch the time carefully. Good. The other thing is psychotherapy. And psychotherapy can be enormously helpful in addition to medication for bipolar depression. And many of you may know these things of cognitive behavioral therapy, and you may not be aware of something called the Unified Protocol that is transdiagnostic, means it can be used for a lot of different diagnoses. And also there are lifestyle interventions that might be helpful. There are a bunch of potential new treatments. Ketamine is also a treatment for treatment-resistant depression, many of you may be aware of. And some of these others are repurposing medications. By the way, the nicotinamide riboside is also a natural treatment that might be helpful for some people. And it's my colleagues and I are just starting to study that. Let's see. So somebody's asking about psilocybin, and I don't think we know yet what's the role of psilocybin for people who have difficult to treat bipolar disorder. As you may know, there's a lot of interest in psilocybin for people who have depression, and especially depression and PTSD. And now is a very active area of research. Somebody is asking, does bupropion reduce addictive behaviors, substance abuse, gambling, and therefore limit mood disorder triggers. Well, bupropion does reduce smoking, tobacco. In terms of other things, I'm not sure if there's good data on it, but believe it or not, there's some data on N-acetylcysteine helping with these things. And again, is an area of interesting research. Let me go to the next thing. So in summary, you know, bipolar disorder, many of you know this. This is not news to you. The thing I do want to tell you, relevant to this, has a complex chronic course. And what I'm happy to tell you is I think within a year or so, there may be unprecedented philanthropic support to study bipolar disorder, and especially its complex chronic course. Stay tuned, and I'm sure you'll hear more about that in the upcoming year. But it really gives me tremendous hope that we might be able to better understand what's going on, because we really don't understand the biological causes. That's the pathophysiology, and we need to understand that really a lot better. Somebody asked, would you type in chat the 2 naturalistic options? I sure will. So one is N, let's see, it's going to let me do this. One is N-acetylcysteine. You can get it from Whole Foods. It's called NAC. And the other interesting thing is nicotinamide riboside. Now, again, the N-acetylcysteine has been studied substantially, and the nicotinamide riboside is theoretical. And let me tell you one other thing, which may surprise you, and maybe it won't. I don't know. You tell me if it surprises you. But there's a very interesting theory that bipolar disorder is not a mood disorder, but instead it is an energy dysregulation disorder. And if you think about it, people with mania have too much energy. People with depression have too little energy. But there are all of these theories now that, at least for some people, it really may be at the level of how we make energy within cells. So there's some of these treatments are related to that, especially the nicotinamide riboside is related to how our cells actually use energy. There's another question which I missed before, which is there any data to support that people with bipolar disorder can be successfully treated without meds and with therapy, healthy environment, and exercise, since so many people feel terrible on the meds? I wish there were data. I think generally in the absence of the meds, you know, some people actually do fine for a long time, but most people don't. And the problem that many of you may know is that without the meds, the episodes keep coming back. And exercise can help tremendously. Therapy can help. Healthy eating, good sleep habits can help. But by and large, every study that has looked at how people do without the meds is requires people to take something, and that's why I think people are really trying to find better meds that have better side effects. But you know, I've been very impressed in the past year or so. I remember I told you that there may be unprecedented philanthropy coming down the pike to study this. Part of this process of getting the philanthropy is sort of all of the major researchers in bipolar disorder have been gathering over the past year to try to figure out what we need to study. And you know, we don't really know what the basic causes are, and we have to really find that find out what's going on. So I'm telling you this because I think there's a lot of hope. That's why I'm telling you that. Somebody is asking, can you? Oh, somebody asked about lithium orotate. So lithium orotate ends up having, you know, tiny amounts of lithium, and my group some years ago tried to study low doses of lithium to see if it really made a difference, and we hoped it would, and it really didn't. But I think there are some individuals who might do fine on low doses, and lithium orotate may be one of the sources for that. But again, you know, there's just not a lot of data for that. Somebody's also asking if you can take something like N-acetylcysteine or nicotinamide riboside in addition to something like Abilify, and you can, but I would do that with who's ever you know, your prescriber, to make sure at least they know about that. Let's see if I can get back in here. Yeah, someone is asking, is Geodon or Vraylar more effective towards depression? There's a negative study of Geodon and there's a positive study of Vraylar for depression. Someone is also asking, is methylation a factor? And there is something called L-methylfolate, and it was studied for unipolar depression. And my group did a very small pilot study for bipolar depression that it seemed to help, but there are no large studies that shows it can help or not. Somebody writes, I've heard about implanting electrodes in the brain similar to what's done for Parkinson's. That's called deep brain stimulation, by the way. And that is something that's being studied. And there is some hope for people who have really, really very difficult refractory courses. That might help. In the time that I have left, again, I'm happy to address any questions in the chat that you have at all. What do you know about bipolar and gut health, and how much of a factor can nutrition play? So I'm collaborating with some colleagues in Australia to try to study that. And, you know, I've also become impressed. I think diet can really help a lot, that you can have a diet that promotes inflammation, or you can have a diet that is anti-inflammatory. And it's just what you would think. You know, you basically, if you listen to your mother and you eat your vegetables and you eat a well-rounded diet, and you know, I don't know if you ever saw the movie Super Size Me, where this guy eats, oh, I forget his name, but he eats only McDonald's and gets supersized. And after a month, he's like really sick because it's so inflammatory. So I think the more vegetables, the more towards a Mediterranean diet, I think that can really help a lot. And I've become convinced that, you know, sort of healthy living, right? Don't drink too much, don't use drugs, eat a good diet, get enough sleep. That can really help a lot. Somebody asked, are the cardiovascular issues correlated to the med side effects or the disorder itself? It is related to both. And there's now at least 3 studies that I've seen in the past year and a half where some of the genes, the genetics that are being discovered about bipolar disorder, and as of today, my understanding there are about 64 genes that have been identified. There's an overlap with the genetic risk for cardiovascular disease. So there's some shared genetic risk. And of course, you know, some of the meds do make things worse. So it can be a bit of both. Is there any correlation between bipolar disorder and Parkinson's, or bipolar and prostate cancer? The last that I looked at the overlap, I don't think so. I'd have to go back, look at some of the latest papers on the genetic architecture, as it's called, and the shared genetic risk. But by the way, just so you know, with these 64 genes or so, they come up with something called a polygenic risk score. And because there are so many genes, it's hard to think about, it's not like you just count the genes that somebody has. But there are certain variants that may make somebody more prone to have the disorder than not. And I think you'll hear a lot more in the next decade about the polygenic risk score, and maybe there'll be a genetic signature that'll help us understand more about the pathophysiology. I do want to just mention briefly about treatment-resistant depression, because I did promise to say that. But I'm happy to answer the questions instead. Is unipolar bipolar continued to be seen as a spectrum? If so, would the energy excess deficit theory affect treatment of both? There are shared genes between unipolar and bipolar disorder, and there are distinct genes for both of them. There's more data that in bipolar disorder, there may be an energy dysregulation, but there's also some data even in unipolar that might be true for some people. I have a great book to recommend to you if you want to learn more about evolution and energy, and it's called The Vital Question. The Vital Question by Nick Lane, and it's really an amazing book that talks about evolution and the way that life came to be the way it is. And I'll type it in here, The Vital Question by Nick Lane. And he's an evolutionary biologist, but there is a theory from Lisa Feldman Barrett. And Lisa Feldman Barrett's theory is that the only purpose of the brain is to regulate your energy, and everything else is a side effect of the brain. I mean, that's an amazing theory, right? It's an amazing theory. And that your brain is telling you what energy to use to go towards something and what energy to use to go away from something, and how do you conserve your energy, right? Because that's why right now we're breathing, right? We're breathing to make energy. We eat to make energy, and that you basically, you're burning this stuff up. So I highly recommend the Nick Lane book. It just blows your mind. It's just great. Eric, do you want me to take other questions? Do you want me to talk briefly about treatment-resistant depression? I'll do anything that's helpful to the group.
Yeah, why don't we get through the presentation, but people can continue putting their questions in the chat box, and we'll take them up afterwards.
Okay.
Yeah.
Okay, so just a little bit on treatment-resistant depression. The widely accepted definition is that if the treatments don't work, if two treatments don't work for you, it kind of puts you in this area of you're just not responding. And I want to make sure that the language is precise, because it's not that the people who are being treated are resistant, it's that the meds aren't working. I want to make sure there's no blame here, right? You're not being blamed for not responding. It's the meds just aren't good enough. This is a very interesting timeline of sort of the pharmacotherapies, starting back in the 60s and going all the way to here. Some of these things have made it, some have not. Many of you are aware of sort of the whole SSRI revolution. Just to give you a context, 1980 is when I started my training. So I've been doing this for 40 years. Can you believe it? When fluoxetine came here in 1987, it was such a game changer. It was so amazing, and it made it much easier to be treated. And then it was followed by a whole bunch of other things. which were similar, except for mirtazopine's a little different. And then came these other ones here of duloxetine and some other things. I'll talk about aripiprazole or Abilify in a minute. Some other variations of things, and vilazodone, levomilnacipran is on, vortioxetine is here, brexpiprazole, which I'll talk about briefly, and then esketamine, right? So this, and there are some newer ones that are coming on that I think have really novel ways of working, and I think also gives us tremendous hope that we can move forward. Let's see, there's another, okay. So this is sort of the general way that people start the fancy word of feeling okay, euthymia, they get depressed, they're treated, they respond, and they go on. And some people do have a relapse in the first 6 months and can have a recurrence thereafter. And one of the problems is that at least half the people who get depressed can have another depression, and you want something that's going to prevent it. So on the newer treatments, esketamine, which is the intranasal form of one of the parts of ketamine. And let me just explain something to you very, very briefly. Ketamine is made of two forms of it. Oh, that's telling me to stop, but I just want to explain the difference between ketamine and esketamine. Nature is really interesting because nature comes in a left hand and a right hand. And many molecules, even though the structure of my hands are the same, you can't overlap them, but they are mirror images of each other, right? And so ketamine is made of a right hand and a left hand, and esketamine is just one of those, right? And there was some theories that maybe that's where it's in the left hand side, that's where the action is. So esketamine was approved by the FDA. Ketamine itself is not, but is widely available anyway. Ketamine itself is an anesthetic, right? And again, this is an interesting study that showed that esketamine plus an antidepressant was better than an antidepressant plus placebo for people who are tough to treat. I'm going to skip that in a minute. So this is just the main thing I wanted to tell you is that, and many of you know this who may have suffered through this, things don't work, you can switch to something else, or you can add something, you can augment it. And the best data exists for aripiprazole, Abilify, brexpiprazole, Resulti, and there's even data for L-methylfolate, but you have to take enough of it. And as I mentioned before, there are these neuromodulation things, the repetitive transcranial magnetic stimulation, electroconvulsive therapy, and vagus nerve stimulation, which is an implant. And somebody mentioned before the deep brain stimulation, which is, for people who are ultra resistant, and that there's some promise for that. So let me stop the sharing there, and I'm happy to entertain any other questions that come up. So
do people have questions they want to ask? You should be able to unmute yourself at this point if you just want to go ahead and ask it, or put it in the chat box.
I have a question.
Sure.
Hi.
Hi.
I was wondering, is it possible for a medication to work for a patient or someone at one time, and then they go off it because they think they're okay, and when they try to go back on the same medication, it actually doesn't work for them anymore?
One of the things I've learned in my old age after doing this for 40 years is that there's all sorts of patterns. And for some people, if they take something and it worked and then they come off of it and then they take it again, it works. And there's some people it doesn't work. So there's all sorts of patterns that people can have. And I wish I understood that. But I've certainly seen people who, that things worked at one time and it didn't work at another time.
If your symptoms change over time, does it really make sense that you're going to be on the same level of medication? Because sometimes you may need more and sometimes you need less. And it's like you feel you're over medicated 87% of the time because the other period of time you may be sick. And so you're just always waiting for this moment where you're going to be sick. So you're over medicated until just in preparation for when you will be sick. And does it have to be that way? Like, can you have an episode? I know it takes a while to get to a therapeutic level, but it's like you're dealing with the side effects for 9 months or 10 months for an episode that may last 2 months.
Yep. Yeah, it's whenever I'm trying to be, I'm trying to collaborate with somebody, because I really do see my relationship with the people I'm helping as a collaboration. Really trying to make sure there's the optimal balance between side effects and like if somebody is worried about having another episode, trying to balance the side effects with the protection. And I want people to have the least amount of side effects as possible with the greatest amount of protection. Now, sometimes get into trouble. I get into trouble because I'll try to lower something to the lowest amount, and then it doesn't protect people enough. And so over time, we kind of find out what's the proper balance, or, can I find something else that won't have such a burden of side effects on people. So I'm always trying to look for something better. In the place that I work is called the Daunton Family Center for Bipolar Treatment Innovation. We're always trying to see if we can repurpose available meds, come up with better meds, figure out something based on a reasonable theory. And that's why I have some hope for things like nicotinamide riboside and the N-acetylcysteine, which may be helpful for people, just to see if there's something better. I hope I answered your question.
And
Yes,
there were
you did. Thank you.
two questions in the chat box. One is, can esketamine be used for bipolar depression? And then, what causes depression after acute mania?
So yes, esketamine can be used for bipolar depression. And there was just a review of that I think was published this week, where the data looked pretty good, but we probably need more studies because each of the studies are kind of tiny. They're really small. And what was the second thing you asked?
What causes depression after acute mania?
No one knows. No one knows. But there's another book I'll refer you to. It's called The Connectome by Stephen Sung, and it'll give you a picture of the networks of the brain. Again, it's called The Connectome. And I'm telling you this because really in many ways our brains are a complex network of networks. And once you have a perturbation in a network, it can be unstable, and then it shifts for reasons not entirely clear. But there are networks in all of nature, right? Nothing is separate. Everything is embedded in a network, and our brains are a good example of that. So remember, I told you there's this big philanthropic thing happening. We had this big meeting today, and people were trying to say, what are the questions that we can try to address? And it came up, why do people switch? Right? What is the switch from mania to depression, from depression to mania? What is that process? Because that's unique to bipolar disorder. And we still don't understand why that happens. We just don't know.
Okay. Next was, how high is the percentage of people without, percentage of people being bipolar without having relatives having no mood disorder?
So there are people who have it without a family history. And again, we don't know why. I can't tell you off the top of my head what the percentage is. So I don't know that statistic.
Okay. Other questions here? I should know also Andy's going to be sending his slide deck to us, and we will distribute that. I'm not sure you're able to do that now, Andy. I don't know if you have that, but if not, you can send it afterwards. But do people have other questions? Not hearing any. I saw several people in the chat box say it was one of the best presentations they ever heard. So thank you,
That's
Andy.
It's very kind of you.
Yeah, well, I appreciate your time.
There is a question about somebody was diagnosed as bipolar NOS, and what is that? So NOS means not otherwise specified, and you know, it's because if you look at the criteria, you know, what do you do if somebody's had depressions and then they have a full terrible mania that only lasts a day, right? The criteria says it has to last for 4 days. Well, so what do you do with that? You say it's not otherwise specified, you know, just because of the criteria. You know, with trying to say that it needs to last for 4 days, you know, people were trying to come up with a language to figure out how long is long enough to make the diagnosis. So the NOS really does refer to, it just doesn't quite meet the criteria.
Okay, gone, as they say. No other questions. I want to thank you. Yeah, go ahead, Alvin. Yeah, go ahead.
Let me add my thanks, and you've seen the comments. I am impressed with your handling the chat in real time, doing a host function as well. So thank you very much for this wonderful talk.
It's really my pleasure, and you know, I really see the collaboration. We all want the same thing. We want people to live full, thriving lives, and to find the best way and the best path to get there. And the you know, that's what we're trying to do together. So you know, it's good.
I see another question in chat. Would you say that the data pointing in the direction of renaming the disorder a sleep disorder or energy disorder is enough to push in that direction therapeutically?
So I'm going to go out on a limb, and I'm going to say that in 10 years, we will have a better understanding where the language will change to physiologic subtypes, right? To understand, because you know, the journal that focuses on bipolar disorder is called the Journal of Bipolar Disorders, and I think that my hope is that in 10 years, maybe in 5 years, but certainly in 10, we'll have a better understanding of this is the way that physiologically there are the dysregulations, and that if you have this type of biology, you need this type of treatment, and you got to match people to treatment rather than what we're trying to do now. So I think there will be a subtype that may be this energy sort of dysregulation disorder on the level of cells and how cells use energy, and how little things in the cells, which are the mitochondria, which generate the energy. I hope that's what we are able to get to. We just you know, we have to make the investment in it, and we have to be able to do it. And somebody's asking about, you know, are there blood tests now? That's the whole area called biomarkers. And currently there are no clinical biomarkers for individuals. And there's a lot of research on imaging and other things in the blood, possibly. And I'll tell you one other thing we're working on, because it'll also blow your mind. But you can now take a cell and turn it into any other cell. And then you can take that cell and turn it into something else. And now there's the technology where you can take a blood sample, turn it into a neuron, and then turn that neuron into a mini brain. It's called a brain organoid. And I'm collaborating with a fantastic researcher whose name is Paola Arlata. And what we're going to try to do is see if we can take the cells from people who have unequivocal sustained response to lithium and other people who clearly didn't respond to lithium, grow these organoids. It's very technical and difficult to do. It takes a long time. And then expose their organoids to lithium to see if we can understand what's the physiology of the response to lithium, what's the physiology of the non-response to lithium. Again, it's called brain organoids. I mean, it's really, really quite amazing. Somebody's asking about genetic testing. I actually collaborate with a genetic testing company in a study, and I'm also on their board. There needs to be more research on the genetic testing for treatment, pharmacogenomics it's called. And it seems to me that the genetic testing helps not so much with what treatments to use, it's what treatments either not to use or use with caution, or you have to vary it. Because most of those genes have to do with how you metabolize the drugs, not necessarily the physiology. So I think we have more to understand, and I think the company called Myriad, which makes the product called GeneSight, I think they're really interested in doing more to understand how to be helpful for people who are taking medications for bipolar disorder. Somebody's also asking, why isn't lithium more widely used, and why has it gone down so much? I think it's a very complicated answer, and I don't really know why, but every guideline that is evidence-based, every guideline, and the best guidelines, by the way, come from Canada. They're called CANMAT, C-A-N-M-A-T. And the CANMAT guidelines, they all say lithium is the first thing you got to try. But I think the younger generation of psychiatrists, again, I told you, I've been doing this for 40 years, which is a long time. And so my junior colleagues, I think, view lithium as more problematic than the other meds. And again, I'm not exactly sure why, but treatment patterns change.
There's a cynical view that the problem with lithium is there's no profit in it.
Yeah, and there may be something to that. I'm not sure, but for the prescribers, it doesn't make a difference. They don't make more money or less money if they prescribe lithium or something else. So and the reality is it's a little harder to use. You have to take blood levels. You have to watch other things. So I think there is a real a hassle factor. But we really need to understand are the outcomes better for lithium than as compared to like the repurposed antipsychotics, and the data suggests the outcomes are better in the long run. It's a little hard to prove, but there are a couple of studies like that.
Once again, I will, hearing no more questions, we want to thank everyone for coming tonight and appreciate your participation. And we will see you all sometime next week at one of our meetings, I hope.